Good morning, and I welcome everybody around the world to the International Menopause Society webinar on non-hormonal pharmacologic interventions for vasomotor symptoms. This is the first in a series of two. The second one will talk about non-hormonal interventions for vasomotor symptoms that are not pharmacologic, and watch out for that webinar. But this morning, I'm so delighted to have two expert speakers from around the world. And where but the International Menopause Society can we meld the experiences of North America and Europe together to get the best speakers in the world? So I'll just do a few housekeeping things to begin with. I'm going to be introducing Dr. Chrisandra Shufelt first. And then before Professor Petra Stute's lecture, I will introduce her. And at the end, we will field questions and answers. And hopefully, if you have any queries, we will answer them. So I want to tell you that this is being sponsored by an unrestricted educational grant from Bessens Healthcare. But Bessens has had no role in the selection of topics or speakers and has not vetted or reviewed the content of the speakers' presentations. So first of all, I would like to introduce Professor Chrisandra Shufelt. She's the chair of the Division of General Internal Medicine, senior consultant at the Mayo Clinic Women's Health, and associate director of Women's Health Research Center at Mayo Clinic in Jacksonville, Florida. Dr. Shufelt is a women's health internist with fellowship training in vascular biology and women's health, and she's a certified menopause practitioner. She has several national and international leadership roles in the American College of Physicians, the European Menopause and Andropause Society, and the North American, or now called Menopause Society, where she is a past president of the society and on the board of trustees. She has over 200 publications in the area of women's health and has also co-authored several scientific position statements on menopause and hormone therapy. Her NIH-funded research focuses on young women with hypothalamic amenorrhea, evaluating the impact on immune and vascular health. And thank you very much, Dr. Shufelt, for speaking to our global audience today. Thank you.
Thank you, Dr. Wolfman, and it's absolutely a pleasure to be here and also to review the most recent position statement by the Menopause Society, formerly the North American Menopause Society, and I'm going to go ahead and share my screen. Because this position statement does cover non-pharmaceutical medication opportunities as well, it was an opportunity to really run through 2 years in the making and coming up with this position statement. So I'm going to review both pharmaceutical and non-pharmaceutical options. I have no disclosures to and no conflicts of interest. And really our learning objective here today is really to talk about this 2023 non-hormone therapy position statement and really the key messages, and focus really on what was the evidence-based decision and really understanding that this is about vasomotor symptoms. This is not about a lot of other subsequent symptoms that we know are associated with menopause as well, but it is specific to hot flashes and night sweats. And what are the areas in the following areas, including lifestyle, mind, body techniques, prescription therapies, obviously that's an important one. We're going to touch on dietary supplements and what the position statement found, and then acupuncture as well as other treatments. And this isn't going to cover the entire full non-hormone position statement. And at the very end, I'm going to introduce a 2-page summary that's available online that you can actually give patients. And it's a handy summary to really review in front of patients and who's the appropriate patients to or to not use hormone therapy in. I think, so again, this was a very collaborative group of members of the Menopause Society. I was a lead, but joined by a lot of collaborators in different areas. As you can see, we have psychologists, internal medicine, OBGYN, psychiatrists, as well as others. And so we recognize the contributions also by our central office, and this was funded by the Menopause Society Education. There was no commercial support, and I had no disclosures for this funding or for this position statement. So to keep it in alignment with the 2022 hormone therapy position statement, this panel for the last 2 years prior to publication assessed the most current and available literature to recommend and not recommend. So we had recommendations as well as non-recommendation levels based on evidence, and they were assigned these 3 categories. So level 1 was good and consistent scientific evidence for the use of or non-use, not recommendation or non-recommendation. Level 2 was limited or inconsistent scientific evidence. And then level 3 was a consensus and expert opinion. There wasn't enough evidence-based research, but based on that, it was the recommendation was based on consensus and expert opinion. Now, for the purpose of this talk, I'm going to really review key points that were directly from the position statement, but then my summary, as well as an editorial comment. What really should be the bottom line and take home for our patient care? It comes down to the fact that this is evidence-based recommendation, but that's sometimes not what we discuss in front of a patient, right? In our exam rooms or when we're seeing or guiding our patient care appropriately. So in order to do that, I'm going to begin with the conclusion. So if any slide you want to pay attention to, this is the real bottom line, and we'll come back to this at the very end. But the position statement supported the use of these current recommendations. And as you can see, of these 8 bullet points, 4 of them are pharmaceutical agents. And so I think that's a real important message that the stronghold for treatment for non-hormone is pharmaceutical options for the non-hormonal treatment of vasomotor symptoms. But importantly, weight loss was a level 2 recommendation. Cognitive behavioral therapy, as well as clinical hypnosis, were level 1. And then all 4 of the medications were considered level 1, including the SSRIs, SNRIs, gabapentin, oxybutynin, which was newly added to the statement, as well as fezolinetant, all of 4 of those level 1. Level 2 and expert consensus also did add stellate ganglion block, but this was on consensus for a select group of patients. So that's we're beginning with the end, but now we'll go through what really is important for non-hormonal options. And I want to state that the position statement is for women who don't have and are not a good candidate for hormone therapy. And the opening of this position statement recognized, as we all do in the menopause world, that hormone therapy is appropriate at the time of the use of menopause in a majority of patients, but recognizing that there's a select group of patients, prior estrogen-sensitive cancers, breast or endometrium, a history of thromboembolism for stroke or MI, also history of pulmonary embolism, VTE, clotting disorders, or high risk for inherited VTE risk factors, severe acute liver disease. So, and then of course we have patients that select to use non-hormonal treatment options by personal preference. And another point being is that we don't want women to not have options thinking that there's just hormone therapy out there, that non-hormonal treatments are available, and while not as effective as hormone therapy, can offer relief to women who are not good candidates for hormone therapy. So to really digest this statement, I thought it would be important to walk through some specific cases as we see our patients in clinic and in our consultants. So I'm going to first talk about lifestyle option. Remember, there was really one specific lifestyle option that was found to be evidence-based for hot flashes and night sweats. So here we have Miss J, and she's a 56-year-old woman. She has hypertension, hyperlipidemia, class 1 obesity, and chronic back pain. She's coming in with bothersome vasomotor symptoms. She's on an antihypertensive, and a dyslipidemic medication, a statin. She's also taken acetaminophen as she needs for back pain. She wants to discuss lifestyle options to make her symptoms feel better. So at the end of the day, what this position statement really recommended is what's currently in blue. And what's currently in black listed here is that there's no strong evidence that lifestyle changes such as cooling techniques, avoiding triggers, really does improve symptoms. women do find an association with certain things. And that's by the time they get to your office, they probably started to avoid those triggers. But there's no strong evidence that we as practitioners should be recommending that these patients avoid triggers. There was insufficient or poor evidence to consider exercise or yoga as a treatment for vasomotor symptoms. Of course, exercise and yoga are important for health and overall quality of life, but specifically for vasomotor symptoms. And while a healthy diet was important for health promotion in chronic disease, there was very limited evidence to suggest specific dietary modifications for improving vasomotor symptoms. And that really does come down to the need for research in this area and evidence-based research, as well as the vast array of different diets that are out there. What's interesting that does work was weight loss, and weight loss may be considered for improving vasomotor symptoms. So I think that's reassuring to tell our patients that, if you can incorporate diet and exercise that will result in weight loss, that will actually improve your vasomotor symptoms. And I think there's a whole new horizon that we can open up to with pharmaceutical agents for weight loss and how that then in turn improves vasomotor symptoms. So the bottom line, again, my take home here is that exercise and yoga, diet are all good for your health, but they have not found to improve vasomotor symptoms. Many women have already tried, as I mentioned, avoiding triggers. By the time they reach your office, they actually know that if they have a glass of wine or if they have sugar during the day, they might notice an uptick in their vasomotor symptoms. But you can reassure your patients wholeheartedly that the addition of weight loss can not only help your overall health, but it will help your hot flashes and night sweats and encourage them to continue to strive forward to that weight loss. Switching gears to mind body techniques, we have Miss R, and she's a 66-year-old woman who never started hormone therapy. At the age of 51, she went into menopause, and she has noticed that her symptoms are worse lately. She's also noticed she's had an uptick in her stress, and she thinks that's also linked to her symptoms. And she stopped going to social events because she's worried people are noticing her symptoms. She's asking for a solution, but she's not interested in medications. I think Dr. Wolfman, if you could mute yourself, I think she just did. Okay, great. How would you advise her? So mind-body techniques, the ones in black indicate that they were not evidence-based recommendations, and the ones in blue indicate they are. So mindfulness-based stress reduction were limited by sample size and lack of control. Therefore, there was not enough data to really recommend the treatment, and paced breathing and relaxation techniques as well was not recommended. In blue, what was recommended is cognitive behavioral therapy, reduces both bothersome and interference associated with vasomotor symptoms, and clinical hypnosis. And while that is a less common technique, it involves very deep relaxation state and individualized mental imagery to reduce vasomotor symptom, both frequency and severity. The conference that's coming up for the Menopause Society in the fall is also going to be talking about and focusing on cognitive behavioral therapy in a separate session, and the techniques that we can learn to counsel our patients, even though we might not be a psychologist in this area. But the recommended CBT is to work with a local psychologist or even use online resources. And cognitive behavioral therapy really focuses on this circle of physical symptom, vasomotor symptoms, how the thoughts interfere with your vasomotor symptoms. So everybody is looking at me. Remember, she mentioned that she's avoiding social events, so addressing those feelings, the anxiety and embarrassment or loss of control, and then the behaviors that are associated with that. So it's treatment that includes both education, understand the physiology of vasomotor symptoms, how those thoughts and emotions impact your physical sensation, and then training and relaxation, cognitive behavioral feedback with paced breathing. So while paced breathing alone had insufficient evidence, in combination with the overall impact of cognitive behavioral therapy, it did actually improve symptoms. So this is what is currently recommended. So the bottom line from my take home is that breathing and relaxations are good, they're healthy, but they don't work for reducing hot flashes. Cognitive behavioral therapy can improve vasomotor symptoms. And then hypnosis is effective. We know that hypnosis can be used. We need to make this treatment option more available and more readily accessible. And what is the future of that could be how we incorporate that through telehealth, through virtual medicine, as well as some online apps that are available. All right, so going to the pharmaceutical options, this was a very deep dive into the current medications and upcoming medications that are available. So we have Miss J, she's returning. She tried weight loss. She had some success, but she's now still having symptoms that are disruptive for her sleep. And she wants to discuss preparations that are medications and prescriptions options for her vasomotor symptoms. Again, she's on the acetaminophen for her back pain, blood pressure, and the statin for her lipids, as well as now metformin. What would you really consider for this? And all of these, I'll recircle back, were level 1 evidence for recommendation for the treatment of vasomotor symptoms. So the selective serotonin reuptake inhibitor and the serotonin norepinephrine uptake inhibitor were associated with mild to moderate improvement of vasomotor symptoms of up to 75% in the 2 lowest starting doses, in a vast array of them used. In the United States, they're used off-label. They don't have an on-label indication, so it's important to quickly mention that to your patients. Gabapentin was associated with improvement with frequency and severity of vasomotor symptoms, and oxybutynin, which is used for overactive bladder, has been used to reduce moderate to severe symptoms, although we cautioned from the statement that in used in older adults, long-term use was associated with cognitive decline. So this needs to be taken into consideration when you're thinking about the age of your patient and the treatment options that are available. And then finally, the newest on the block is fezolinetant, which was obviously the first in-class neurokinin B antagonist, approved in the United States in May of 2023. I did read most recently approved as in Switzerland in December, as well as throughout some of the EU countries. But this is a level 1 evidence recommendation for the management of vasomotor symptoms. As important as what non-pharmaceutical agents were recommended is pharmaceutical agents that were not recommended. And the 2 that were not recommended were, the one that was not recommended, as it was from the previous statement, is pregabalin. It's not recommended for vasomotor symptoms because of more of the adverse events associated with it. It is also a controlled substance in the United States, so it requires a separate medical licensure, although we do recognize that gabapentinoids or gabapentin in some areas of the United States can also be a controlled prescription restrictions. We felt that the adverse events as a consensus was outweighed the benefit, if any, that they were getting from any of the vasomotor symptoms. And clonidine was not recommended, and that was actually removed from the previous statement because of the adverse events. No recent studies since the 2015 non-hormone position statement updates had found greater benefit than placebo. So that was removed from the previous statement. So what would you recommend in this situation? It's really shared decision-making and coming down to that patient that's sitting right in front of you, as well as other complaints. So let's consider each of them in her. So number 1, these are not in any, these are all written in alphabetical order, not in preference of treatment for her, but we have fezolinetant. This is a 45 milligram daily. Possible adverse events included headache in the clinical trials. In the United States, it's recommended to check liver function tests before and then at 3, 6, and 9 months during treatment. But otherwise, very minimal adverse side effects, very well tolerated in patients, and something that could be considered in this patient as she goes forward with her vasomotor symptoms. Gabapentinoid was the next one. Now, starting clinical pearls is starting low. In women, some of the adverse events can be somnolence or dizziness, so dosing it at night at 100 to 300 milligrams at bedtime, increasing up to 600 and 900 daily if needed. Most of the clinical studies that were done focused around the dose around 900, but certainly women do have symptoms. Reliefs can be up to 12 weeks long, so it's not an early onset of action. So you need to prescribe this and encourage your patients to continue to take it for that full effect to see if they're going to get relief, as long as they're not having adverse side effects. So typically the adverse effects, as mentioned, improve with time. But if you do start out slow and low, you can titrate up over time. And specifically, these also help with night sweats. Because the patient complained of back pain, this might be a good 2-for-1 because she had back pain associated symptoms, and she had vasomotor symptoms specifically at night that she could have relief with both. The SSRIs, SNRIs, the oxybutynin was next. This is really research out of the oncology area and really first discovered in patients that were using oxybutynin for overactive bladder symptoms after breast cancer and reportedly decreased vasomotor symptoms. The mechanism of action is unknown as to why it works at the level of the hypothalamus and for vasomotor symptoms, but it's to start at 2.5 milligrams daily, increase to 5 milligrams twice daily after 1 week. Adverse effects can also be dry mouth, urinary difficulties, but if you have a woman who complains of overactive bladder at the time of menopause, this also might be a good option to cover 2-for-1 diagnoses. Long-term use, as I mentioned, associated with cognitive decline, especially in older individuals. So be cautious about prescribing in older individuals. SSRIs, SNRIs, paroxetine, citalopram, escitalopram, desvenlafaxine, venlafaxine. These are all common antidepressants, and we now know, based on the physiology of the hypothalamus, on where the thermoregulatory area is that controls hot and cold perception, is under control by serotonin. Estrogen would promote serotonin, and with the withdrawal of estrogen, or the use of anti-estrogens like letrozole for treatments, we know that changes the thermoregulatory perception and the imbalance in this area of the hypothalamus. So by giving back a woman low doses of SSRIs, SNRIs, allows the ability to hold on to serotonin in the synaptic cleft, and that's actually how this medication is brought to be of work as a non-hormonal. I do mention that because I talk to my patients about it. I tell them this is not a prescription for depression. I know you're not depressed, but also a 2-for-1 is if they are depressed or have any anxiety, this is a good medication to use and to suggest as a non-hormonal treatment, because even at low doses, you're going to get improvement for both of those. Possible adverse effects, GI symptoms, typically improve over time. I tell my patients to have it with food for the first week or so, and then they can take it on an empty stomach. For women using tamoxifen, treatment for depression, prevention of breast cancer, paroxetine should be avoided, and consider medications like venlafaxine. So take those into consideration because of the liver metabolism and interaction with tamoxifen. So all in all, the non-hormonal medications that were recommended and the doses that were recommended. So the bottom line being, there are several prescription therapies that we know to treat vasomotor symptoms. There are only 2 in the United States that are FDA approved for the use, and that's paroxetine at 7.5 milligrams and fezolinetant at 45 milligrams. And we hope in the future that there will be more medication options in these class of drugs. And use shared decision-making and selectively tailor to your individual patients, their current medical conditions, or any other concerns that they might have. And to round it out, we did investigate and do a deep dive into dietary supplements and cannabinoids. So this is Miss R. She's 47. She had a pulmonary embolism while she was on OCPs, combined oral contraceptives. Her friend told her that cannabis for her hot flashes can help. And she's asking also about over-the-counter supplements because they're advertised to improve hot flashes, night sweats, a host of other menopausal symptoms. And how would you advise her? Well, the panel really looked into all areas, and given the lack of rigorous evidence-based research we did not support the use of any over-the-counter supplements or herbal therapies for the management of vasomotor symptoms. Cannabinoids were not recommended also for the treatment of symptoms. There was sparse research in this area, but of the research that was shown, it did not improve. Given the mixed evidence for For vasomotor symptoms, however, soy foods was removed and changed into a not recommended category, and the extracts and soy metabolite equal were not recommended. And to follow up on that, a recent meta-analysis has also been published in menopause, given that same recommendation. So bottom line for these areas is, despite lack of evidence, it should be part of your medication intake. A lot of patients are using over-the-counter supplements. So you need to talk about the details of that in addition to medications. There's really mixed data for soy, and not a lot of data for support that it's used for hot flashes. Does that mean that a woman should stop taking soy intake? If a woman's been using soy her whole life, I say continue taking it. It doesn't mean that you should be adding it to your diet or taking the supplements at the time of menopause. And we recognize that there's a 20 to 30% placebo improvement rate across all menopausal studies, whether you're looking at hormone replacement therapy studies, randomized clinical trials, but there's also these in the non-hormonal treatments. And that placebo improvement can be up to 66% in patients that have anxiety. Finally, we didn't look into evidence for acupuncture, traditional acupuncture, and then electroacupuncture was in more rigorous studies, needed more rigorous trials before it can be recommended. Stellate ganglion block involves an injection of anesthetic agent by a pain specialist into the bundle of sympathetic nerves in the neck. So it might alleviate moderate to vasomotor symptoms in select women, but there is always the potential of risk. So we caution the use despite giving it a level of evidence. And the calibration and chiropractic interventions really did not recommend for vasomotor symptoms. So bottom line, stellate ganglion block in a select group of patients with an experienced group of anesthesia. Acupuncture studies really are heterogeneous, and they do lack a control group or a sham acupuncture group, or the control groups are waiting control groups. And so there's few studies that really do, the data is really mixed in this area. And I think this is an important area because women also seek treatment for acupuncture for other reasons. For a few side effects, it's very side effect free. It doesn't interact with medications. So if a patient's using it, that's important to note. Again, coming back to our summary, this was the important slide at the very beginning to pay attention to. 4 evidence-based level 1 medication pharmaceutical agents, the SSRIs, SNRIs, gabapentin, oxybutynin, and fezolinetant. The 4 non-hormonal, non-pharmaceutical recommendations were weight loss, cognitive behavioral therapy, clinical hypnosis, and the stellate ganglion block. So I will end with that. We did not find evidence for the following up until the fact that you can see all of these listed here. And then I mentioned that we would be summarizing it with a 2-page meno note. So this is available on menopause.org. This is by the Menopause Society, a non-hormonal treatment for hot flashes and vasomotor symptoms. And it is written for patients. It is written and outlined, but is also a tool that you can walk through what is recommended by each point-by-point line to find out what is the best fit for your patient. So I thank you for your time, and I thank you for this invitation. I look forward to our discussion.
Thank you so much, Chrisandra, for that wonderful summary. And I'd just like to give a plug for the International Menopause Society and encourage anybody who's watching today to consider going to our amazing website and joining, and consider doing the Impart, which is a course that you can take on menopause and becoming active if you are located around the world. So our next speaker is Professor Petra Stute. She's Deputy Director, Gynecological Endocrinology and Reproductive Medicine, Director of the Menopause Center, Department of Obstetrics and Gynecology in Southspital, Bern. She's the leading physician of Gynecologic Endocrinology and Reproductive Medicine, Department of Obstetrics and Gynecology in Southspital, Bern, Switzerland. She's EMAS Vice President and Board Member of the German Menopause Society. So it gives me great pleasure to introduce Professor Petra Stute today. Thank you, Petra.
Yes, thank you very much for the introduction. And it's a pleasure for me to present my slides to you now. And hopefully it's also working. Okay, so now you should see everything. So yes, welcome again from Switzerland. And as you've already heard in the previous presentation, there's a new product on the market which addresses the cannulins, and this is going to be my topic within the next 20 or 25 minutes. Here you can see my disclosures, and most importantly, the regulations for phasolinetant are slightly different from authority to authority. So that's why I encourage you to have a closer look at your package insert wherever you are living. And my focus is going to be on the European approval. So now I will introduce to you your next two patients, and I'm pretty sure you will know them. So the first is Wilma. Wilma is 54 years old. She's postmenopausal. She's quite healthy. She's a smoker, and she has a normal body weight, and she has hot flashes. And her friend Betty, she's a little bit younger, so she's 52 years old. She's also postmenopausal. She has just been diagnosed with breast cancer, and this is why she's taken an aromatase inhibitor. And no surprise, she also has hot flashes. And the two women have heard about a new product, and that's why they are coming for consultation to you. And the product they've heard about is called Veosa. And the medication itself, or the drug itself, is called phasolinetant. And it was approved, as you have already heard, in the United States in May last year, and by Swissmedic and by EMA in December 23. And interestingly, the indication for Veosa differs slightly from the authorities, but in the EMA approval, the indication for phasolinetant is the treatment of moderate to severe vasomotor symptoms associated with menopause. And now you may wonder, what is phasolinetant? So first of all, phasolinetant is not a hormone, and it has its role in the thermoregulation. So you may already know that in our hypothalamus, we have so-called cannulins, and the cannulins, they regulate the thermoregulatory center, also located in the hypothalamus. And usually there is a balance between neurokinin B, which is stimulating cannulins, and estrogens that are inhibiting cannulins. And now when the estrogen levels are decreasing due to menopause, then somehow the neurokinin B has won the game, and which means that the cannulins are stimulated all the time, and they become hyperactive, and this is the reason why women develop hot flashes. And in order to get approval for this new product, there was something set up called Global Bright Sky Program. And here we have overall 5 studies. The first 3, they are all published, and I will show to you just shortly the main results of those Skylight 1, Skylight 2, and Skylight 4 studies. And the Moonlight 1 and Moonlight 3 studies are still ongoing in Asia. So as I already said, I will shortly summarize the study design of Skylight 1 and 2. These are identical studies, and women with vasomotor symptoms were randomized to placebo or phasolinetant 30 milligram or phasolinetant 45 milligram. And after 12 weeks of treatment, the women that had received placebo now were switched to either phasolinetant 30 milligram or phasolinetant 45 milligram. And the whole study duration or intervention time was 1 year, with a short follow-up afterwards. The second or the third study, which is called Skylight 4, is the safety study for phasolinetant. So again, women were either treated with placebo or phaseolinitin 30 milligram or phaseolinitin 45 milligram for 1 year. And here the endpoints were adverse events and of course endometrial changes. And just to answer your question about endometrial safety, that's given for phaseolinitin. So now Wilma, of course, has a lot of questions about this new product. And now you are asked to answer all these all these questions. So the first question that she has is, how effective is Veoza in reducing the frequency of hot flashes? Second question, how quickly will I notice that Veoza is working for me? Third question, how likely is it that Veoza will work for me? And her fourth question, what could be the reasons why Veoza might not be working for me? And how long can I take it if it works? And will Veoza work less well or better the longer it is used? Okay, so let's start with her first question. How well does Veoza work in terms of the frequency of hot flashes? And these are the results of Skylight 1 and Skylight 2. So what we can see here on the slide is that after 12 weeks of treatment, phaseolinitin significantly reduces the frequency of hot flashes. And after 4 weeks of treatment, phaseolinitin reduces hot flash frequency by 55% versus placebo, 30%. And after 12 weeks of treatment, phaseolinitin reduces hot flash frequency by 64%, whereas placebo reduces hot flash frequency by 35%. And the same results apply for VMS intensity. So the second question, how quickly will I notice that Veoza is working for me? And here, if we have a very close look now at the figures, we see that the lines for placebo and the lines for phaseolinitin separate quite quickly. So the answer is that usually women will notice a difference after 1 week of treatment. Now, how likely is it that Veoza will work for me? And here on these two figures, we see the percentages of participants with at least 50% reduction of VMS frequency or at least 75% reduction of VMS frequency. So the answer to this question is, it's quite likely that Veoza will work for Wilma, as the number of hot flashes was reduced by at least 50% in almost 60% of women after 12 weeks of treatment with phaseolinitin 45 milligram per day. So what could be the reasons why Veoza is not working for me? Well, of course, there's never a 100% guarantee of effectiveness. However, in a sub-analysis, it was found that at least the factors age, ethnicity, BMI, time since menopause, VMS duration, VMS frequency, and VMS intensity at baseline do not play a role. How long can I take it? Well, if we now have a look into the package insert, we can read that no data are so far available for a treatment duration of more than 12 weeks. However, benefit of long-term treatment should be periodically assessed, since the duration of VMS can vary by individual. And we all know that the median duration of hot flashes is about 7.5 years. So will Veoza work less well or better the longer it is used? So now we have a look at the results for the whole duration of Skylight 1 and Skylight 2, which was 1 year of treatment. And we can see that during all these weeks of treatment, the effect is stable. So the answer is that Veoza most likely will work consistently well for Wilma. Now, of course, Wilma has more questions because she's somehow also concerned about safety issues. So now she's wondering what side effects can occur, and what about liver enzymes? Will there be a possible increase within the first weeks or month, or only after a longer period of use? And do the liver values go down on their own? And if So how quickly? And what are the contraindications? And what about tumor risk? So she has heard about a paper that was published last year. So now she's a little bit nervous about this. So let's start with her first question. What about side effects of fezolinetant? Again, we can have a closer look into the package leaflet. And here we see that common side effects were insomnia, diarrhea, abdominal pain, and liver enzyme increase. So that's why we focus now on the liver values. So we have seen that this may occur. However, the question is, will the liver enzymes increase right after starting the product, or are they going to increase later on? And this is, of course, the question, if it's necessary to really monitor them all the time. So the answer to this question is that the liver enzyme increase, or also the increase of bilirubin, took place at different times during the entire duration of the study. And there was no specific time profile or duration until an increase in liver enzymes or bilirubin occurred in any of the three groups: placebo, fezolinetant 30 milligram, or fezolinetant 45 milligram. And there was no dominant pattern for the rise and fall of liver enzymes. And there was also no specific patient risk profile that would have predisposed to an increase in liver enzymes. So then she's wondering, so if the liver enzymes would increase, how quickly do they go down again? And here we can based on the studies that were on Skylight 4, we know that the enzyme or liver enzyme elevation was generally asymptomatic, isolated, intermittent, or transient, and usually returned to baseline during treatment or shortly after discontinuation. And never in any of these three studies, Skylight 1, 2, and 4, there was never an indication for liver cell injury. And if we specifically look at those women that had an increase of their liver enzymes in the fezolinetant 45 milligram group, then within 1 month of diagnosis of an increased liver enzymes, within 1 month, the liver enzymes had dropped again. And this was irrespective of discontinuation of the treatment or continuing the treatment with fezolinetant. What are the contraindications? And interestingly, this differs a little bit from package insert or country to country. So in the European countries, co-medication with moderate or strong CYP-A1/2 inhibitors is a contraindication because fezolinetant is metabolized by CYP-A1/2. And then, of course, if you take an inhibitor for this enzyme, then you might have an higher endogenous exposition to fezolinetant with a higher risk of side effects. So in Europe and also in the US, only moderate and strong CYP-A1/2 inhibitors are contraindicated, whereas in Switzerland, also weak CYP-A1/2 inhibitors are a contraindication. Then, as always with drugs, hypersensitivity to the active ingredient is a contraindication, and of course, pregnancy. But as it's indicated for menopausal women, pregnancy in general shouldn't be a time point when you should consider fezolinetant. So what about now the tumor risk? Because there was a paper published in the Lancet last year, which caused a little bit of rumor, let's put it this way. So what did they do in this paper? So they collected the tumors that were diagnosed in Skylight 1, 2, and 4. And tumors now means benign tumors, malign tumors, and also tumors of unknown significance. So in Skylight 1 and 2, there were two tumors identified in fezolinetant, or overall 4 tumors in Skylight 1 and Skylight 2. And as Skylight 1 and Skylight 2 did not have a placebo arm for the whole year. That's why there are no tumors listed for the placebo arm. And in Skylight 4, in the fezolinetant treatment group, there were 14 tumors, and in the placebo group, there were 2 tumors. So overall, we have 18 patients in whom 23 tumors were diagnosed. And of those 23 tumors, 12 were malignancies. And you can see in brackets, I put very different kind of malignancies that were identified. So then a meta-analysis was performed, and using a special statistical method. And according to this special statistical method, the risk of tumors was increased with fezolinetant. However, first of all, the Skylight 1, 2, and 4 studies were not designed to assess tumor risk. And you can see also in the absolute numbers that overall the number was quite low. And also the statistical method that was applied is usually not the best one to assess rare events. So the conclusion after all this analysis still is that the current non-clinical and clinical data does not indicate an increased risk of neoplasms. So now we turn to Betty. So Betty, you remember, she has been diagnosed with breast cancer, and she has hot flushes, and she has to take an aromatase inhibitors. So now, of course, she would like to know if she can also use fezolinetant, although she has been diagnosed with breast cancer. And secondly, she would like to know if her aromatase inhibitor would be compatible with fezolinetant. So let's focus on her first question. And again, now the package inserts differ from authority approval to the next one. So this is what we can read in the European package insert. And here we can see that women diagnosed with breast cancer who are currently using or undergoing oncologic treatment, that they have not been included in Skylight 1, Skylight 2, or Skylight 4. And this is why fezolinetant is not recommended in those women. Then women with previous breast cancer who are not currently treated with an oncological treatment, they, of course, were also not included in Skylight 1, 2, and 4. However, here the benefit risk consideration should be individually made with the oncologist, the gynecologist, and the patient herself. Interestingly, for example, in Switzerland, our package insert does not differentiate between women with breast cancer who are still treated and those who are not treated anymore for breast cancer. Here, our package insert only says that those women were not treated or not assessed in the Skylight 1, 2, and 4, and that it's always an individual benefit risk assessment. So Betty's second question was if the aromatase inhibitor is compatible with fezolinetant. And now we have a look at the list of so-called SUB-A1/2 inhibitors, which are contraindicated in women using fezolinetant. And here on this list, we don't see aromatase inhibitors, and we also don't see tamoxifen. So which means that at least aromatase inhibitors and tamoxifen are not SUB-A1/2 inhibitors, and that's why we at least could think about prescribing fezolinetant to those women, although the leaflet says to be very cautious. Probably also very important, fezolinetant does not inhibit or induce other CYP enzymes. So now I come to the conclusion. So candidneurons are involved in thermoregulation, and with the drop of estrogens due to menopause, their inhibitory effect goes away, and the candidneurons become hyperactive, and that's why hot flushes occur. Neurokinin receptor antagonists reduce hot flushes, and on the market is fezolinetant, and elinzanetant is most likely the next product that will be on the market, probably also maybe this year or next year. I don't know about this, but you will see that there will be at least 2 products available out of this treatment class. And fezolinetant significantly and rapidly reduces menopausal hot flashes. It has a good safety profile, and it was approved by the FDA in May last year and by the European medical agency and Swissmedic in December last year. So thank you very much.
Thank you very much, Dr. Stute. I think we could get a lively conversation going between the 3 of us, and we do have some questions. I'd sort of like, if any of the participants want to ask a question, please put them in the question and answer format. So first of all, I'd like to ask Dr. Shufelt, because maybe you have more experience practicing with this medication, fezolinetant. Have you seen patients with significant side effects on this medication? How do you feel about it? What about the insomnia and the diarrhea? We really haven't talked about that very much. And have you seen liver function problems in your prescriptions?
That was for me, right?
Yeah, for you.
Okay, sorry, I missed the intro. I have had probably close to a dozen prescriptions for this medication. It is a challenging medication, especially in our older individuals over 65 due to coverage, but we have had success in getting it prescribed. I have not seen an uptick in liver enzymes in all the patients that I've checked, and I've checked them out through 9 months now. I wholeheartedly and anecdotally have an N of 1. A patient came back to me and said that she didn't know what life was like without a hot flash until now. So I just, I think everything is moving in the right direction for menopause non-hormonal care, because that's an area of my cardiovascular research, and an area of interest is that I see a lot of women that are not good candidates for hormone replacement therapy, menopause hormone therapy. And I think if we have an added tool to offer these women, it's a benefit. So I wholeheartedly support that we are actually exploring and finding out this mechanism. So that is my N of 1, and the other ones I've done very well on it as well.
Do you, both of you, know whether it is being looked at in breast cancer patients in trials by the pharmaceutical companies or anybody else?
Oh, interestingly enough, I had one of our oncologists reached out to me last week and asked if it can be used in patients taking letrozole and men taking letrozole. So I did reach out and ask to find out if there's any studies going on in this area, and the answer, well, specifically for men, which I think is also an important area that we do need medications also for men in this with vasomotor symptoms due to withdrawal, and it is not right now. I haven't heard anything else in that space.
So I was told that for fezolinetant, breast cancer study is planned, and for elinzanetant that they already have a trial ongoing, and then I think all of us are very excited to get their results.
Right, because this is a huge population that has tremendous symptoms, and we all know that sometimes the medications, women will stop them, and because of the side effects from their medications, and this may have impact on their eventual survival. So we really need studies in this group of people. The other question Dr. Shufelt posed is, do you think there is a role for the new weight loss medications in the treatment of hot flashes?
Yeah, so one of the evidence-based research that we looked at for weight loss actually had one medication on there that was studied. It's no longer on the market, but it did show using this one weight loss medication about a decade ago improved vasomotor symptoms. So I'm hopeful that a lot of these medications that can be used for weight loss can actually also improve and better overall quality of life when it comes to menopausal care. I mean, I think every one of us, you know, outside of the top complaints of hot flashes and night sweats and perhaps insomnia, I think one of the top three is always weight gain at menopause. And if we can mitigate the weight gain that and then improve vasomotor symptoms, I think that's an opportunity for success. And so I think with these with some of the new injectable weight loss medications, it's an opportunity for research. So I think I'm hopeful that that can be.
Okay. A question from Sarah Ball. In the US, it is advised to check liver function tests, but not in Europe. Does Professor Stute check liver function tests in her patients? And also, she commends you both on your presentations, which I concur with.
Yes, so thank you for this question, because I think it's very interesting how the authorities want or have different opinions on liver enzyme monitoring. So in Europe, you're right, it's not necessary to check any liver enzymes. In Switzerland, we have to check liver enzymes at baseline and after 3 months. So that's what I'm doing at the moment. I also haven't seen an increase so far. However, we only have it since January on the market. So my experience is not that big as with Professor Shufelt. And yes, so surprisingly in Europe, it's completely different.
Okay. What about the effect of foods on CYP1A2? Coffee, grapefruit juice, cruciferous vegetables that increase the metabolism and could result in lower levels of the medication. Anybody know about food effects?
Not really. So usually when you have a look at those lists, it's more about drugs that are CYP1A2 inhibitors. So I would just guess that as the food and the amount of food probably varies from person to person and from day to day, that it's difficult to say something about food, even if it's maybe a modest CYP1A2 inhibitor. But to be honest, I've never read anything about this.
What about age limit? We have data up to age 64. Have you prescribed it in older women?
I haven't, but maybe Professor Shufelt has.
I have in one woman, and it was because it was so refractory to other treatment options. I did exhaust all other options prior to that. And again, this was a woman who came back and said, I didn't know what life was without a hot flash. So while it hasn't been studied, it's an N of 1. And I do, you know, we do put buckets into women's health. And I do think that it is, even though it's a 65 and older, it's still an important age range that we should be considering.
We haven't talked about bone, calcium metabolism. Is there any data if this has any effect on bone?
I'm not really aware. I somehow remember that there were some, I'm not sure if it was bone metabolism data or really bone densitometry data, but I think in the end, what I remember that there was not a huge impact. But of course, it's not preserving bone density or bone mass.
Cassandra, do you know any? I don't know of anything.
No, I don't know. I know it was, I think Skylight 3 or 4 did look at bone loss, and they did not find it was associated with bone loss, but bone preservation, I don't think it's been evaluated.
Someone asked about using this in the late perimenopause. That might be a little problematic if you're not sure about pregnancy. Anybody want to answer that?
Yes, so if you are unsure, probably it makes sense to perform a pregnancy test. And interestingly, again, in Switzerland, it's officially only approved for postmenopausal women, whereas in the US, I think, but at least in Europe, it's approved for vasomotor symptoms associated with menopause, which means that officially you could also prescribe it in perimenopausal women. And most likely in the Skylight studies, as the inclusion criteria is always that you have to have at least 6 months of amenorrhea plus a certain level of FSH. Probably also some late menopausal women have also been included in those studies. But of course, to be sure, you always have to do a pregnancy test to rule that out.
And again, this goes back down to the age buckets, right? It's been studied in menopausal women and not in pre or perimenopausal women. Therefore, it has that indication for menopausal women. But even with other modalities for non-hormonal treatments, we do need to talk about perimenopause because a lot of these vasomotor symptoms are raising their head during perimenopause. And then we do need to address pregnancy. So if you have if a woman has a contraindication to systemic menopause estrogen treatment due to a cardiovascular complication like a VTE, not a breast cancer, but I'm talking about a cardiovascular implication, you could consider, this would be a consideration of a progestin IUD with the addition for the treatment, a non-hormonal treatment, because that would actually help cover the pregnancy risk. And a progestin-only agent is not a contraindication for a woman who's had a cardiovascular complication. Cancers may be a different standpoint, but I will say POPs as well as IUDs are commonly used in patients with cardiovascular complications. And if they still have symptoms of vasomotor symptoms, you could consider adding on that. But it does layer on a little bit of discussion for the pregnancy.
Can you repeat when Veoza should be taken? Once daily, morning, night, just some practical uses of prescription.
So, Professor Shufelt, do you want to answer or?
Yeah.
I can also, well.
I have not differentiated whether you should take it in the morning or at night. Obviously, if they're taking concomitant medications like a thyroid, space it out, but I do have them just take it once a day. There's no preference. Consistency is important.
And also in the leaflet, it doesn't say a specific time point, and it doesn't matter if you take it with a meal or without a meal.
Just a comment from a British dietitian who says that their association has recommendations about coffee and alcohol, trying to cut down on foods likely to trigger coffee, alcohol, and spicy foods. I know that the Menopause Society couldn't find good prospective randomized controlled data for that, but maybe, Chrisandra, you could comment.
As I mentioned, I think a lot of patients do avoid their triggers. They know some of their triggers, whether it's alcohol, whether it's caffeine. I do have the discussion, but there's been no clinical trials to suggest that there is benefit. Anecdotally, these are things that patients have likely already avoided by the time they come in to see you. And I do think that the dietary interventions, specifically for vasomotor symptoms, there's a lack of research in this area. So we're not saying we're making a statement that there's more research, that the research didn't support it, but that doesn't mean that if you have a patient in front of you telling you that if they drink their coffee or they have their martini, they're going to have vasomotor symptoms throughout the night.
Yeah, I think it's an individual decision. And obviously, if someone says that every time they have a drink, they have a hot flash, you're going to tell them that that's probably not a good idea then. Okay, what about the duration of therapy? I think we did answer that, but maybe someone could say.
Officially, it's 1 year because there's no data for a longer duration of treatment. But of course, you can discuss with the patient to continue if, everything else is fine and you have checked the liver enzymes. I think it's fine to continue.
Someone wrote, don't you think there's a risk for patients to use only a symptomatic drug for vasomotor symptoms? What about the other silent diseases that are occurring, such as bone loss, cardiovascular disease, and symptoms not related to vasomotor symptoms?
Yeah, that's sure. So that fazolinetant addresses hot flushes, but of course cannot replace the impact hormone replacement therapy has with all the other benefits that come with HRT. That's true.
And I think the bottom line is that the statement as I opened is that the first paragraph is that for women who are healthy at the time of menopause that don't have any contraindications, that the first line of treatment and so supports the use of menopause hormone therapy. And that's the 2022 position statement, and it's echoed and really underscored the need to reiterate that we aren't putting out a position statement for women to not use hormone therapy, because we certainly know all the estrogen receptors throughout our whole body and the benefit that we see in healthy women at the time of menopause. But for women that have stark contraindications, and that is why it's important to discuss all the other options, and specifically the pharmaceutical options, which had the strongest level of evidence.
So you don't think this is going to replace menopausal hormone therapy?
I don't think it should be replacement for menopausal hormone therapy. And I think that that's the message also that we were coming across, is that women shouldn't suffer in silence if they don't have an option, or if they have a contraindication, or they selectively choose not to use hormone therapy due to other personal reasons. But we should not be dissuading patients from that option.
Do we have any data about what fezolinetant or the neurokinin B receptor antagonists do to the cardiovascular system?
Mm-hmm.
Well,
go ahead.
Oh, go on.
I said that's a great question, and studies are underway to look at the vascular impact of fezolinetant. I mean, it's along the same lines of what is the withdrawal of estrogen, and is there a role for the hypothalamic disruption that occurs? And we also know that vasomotor symptoms through the SWAN study has been associated with future cardiovascular risk when you look at severity and duration of vasomotor symptoms. So mitigating the vasomotor symptoms, we still don't know if that can improve that risk, but I think studies are important and ongoing.
Someone wants to know, can you add oxybutynin on top of hormone therapy? Or can you add an SSRI on top of hormone therapy, or a gabapentin?
So my first question would be, if a patient's on menopause hormone therapy and they're still symptomatic, my first question would be, number one, are they absorbing it appropriately? Number two, is it the right route of delivery? And number three, is it the right dose? Because presumably hormone therapy should be about 90 to 95% effective for vasomotor symptoms. So if they're still having symptoms and you're titrating up, one, to get a serum estrogen level. Not commonly, we don't check it often, but to see if they're absorbing it, or is it the right formulation for them, or is it the right dose? And number two, is it an alternative diagnosis? I mean, is there another reason that they're having vasomotor symptoms on top of you giving hormone therapy? So is it to not put our blinders on for menopause and think about things like thyroid disruption, diabetes, infections underlying that can cause hot flashes as well as cancers? So while yes, you can layer them on together, my first question would be to investigate why they're still having symptoms if you've currently titrated or tapered up.
Okay, does fezolinetant have any effect on mood or weight?
Not as far as it's known. So it has been shown, at least in one Skylight study, that sleep also improves. But of course, this also needs more studies, because the inclusion criterion for the Skylight 1 and 2 were hot flushes and not depressive mood or not insomnia.
Okay, I think we've got through most of this. There is a comment that bone density was, as you mentioned, I think Petra in Skylight 4, there was a study, or there was bone density looked at, and there was no impact in Skylight 4 over 52 weeks. But again, not long-term data, and no real data about calcium metabolism, etc. And one other one, citalopram and fluoxetine are mentioned in your slides, Petra. there may be a number of patients who have chosen not to have hormone therapy or have contraindications, where should you wean patients off this medication before trying Veoza?
So if one of my patients is using a CYP-A1/2 inhibitor, I would talk to the colleague who has prescribed this in order to ask if we could switch it to another medication before prescribing fezolinetant.
Okay, and can you use the medication in patients with a history or risk of DVT or stroke?
Yes, so it's not a contraindication if you have had these events in the past to use Veoza.
Okay. There have not been head-to-head trials with fezolinetant and hormone therapy, correct?
No.
Correct.
Okay, and someone wants to know about why doesn't soy work?
So
Okay.
the soy trials that were published since the 2015 position statement, this was the update from 2023, were very difficult to summarize because of the wide variations that were really seen. There were things studied with soy-based drinks, soy isoflavonoids derivatives that were in tablets. There were studies combining soy with exercise, or just mixed in other supplements such as herbal vitamins or minerals. So it was a wide variety for varying dosages as well. So these studies also were very small sample sizes, and combining that together, they reported different lengths of checklists of symptoms. They didn't always look at vasomotor symptoms. So it was really difficult for us to assess this as a recommended treatment specifically for vasomotor symptoms. And then most patients reported improvements after 12 weeks, but meta-analysis suggested different. So I think at the end of the day, we did find that it was important that we could not show a benefit over the placebo when you look at all the meta-analysis, and soy was less beneficial than other treatments that we recommended.
Okay, so thank you both so much for your time and your effort, and for all our participants today. And I just want to tell everybody about our biannual meeting coming up in Melbourne, October 19th to 22nd. I hope that you will all join us post-pandemic in beautiful Australia. And I also want to ask you to please come to our website and look at all the wonderful educational opportunities we have there. And there are exclusive offers for IMS participants. You can do IMPART. You can participate in our webinars and also access our educational materials. And we have also a clinical colloquium that is available. And I would encourage everybody to join our organization, which is an amazing organization. We also have partnerships with other types of international organizations. And there's a free 1-year IMS membership if you complete IMPART. So thanks so much again. And I look forward to seeing you next month. Bye-bye.
Bye-bye, everyone. Thank you.